Hey, Concord providers. This is Dr. John Jones, Chief Medical Officer for Concord Medical Group. Today, I just want to touch on several aspects of pediatric emergencies. The talk will be a bit lengthy, but hope you'll stick with me throughout the whole thing. As we look at several facilities practicing pediatric readiness and getting ready for that pediatric readiness program, this information will be helpful as we as providers who work in largely adult hospitals or general hospitals. Pediatrics is a big part of our practice. In most places, represents about 20 to 25% of our practice. And so we as providers certainly need to be ready to take care of those pediatric emergencies that we see. We're going to start very basic and work through several aspects. I'm still a big believer in ABCs coming first. And so we'll start with A, and that's airway emergencies. Certainly, airway is the most important thing to address initially because without the airway, oxygenation and ventilation doesn't occur and organ failure follows quite readily. In pediatric patients, respiratory arrest is far greater than cardiac arrest. These kiddos normally have a nice, healthy heart, and when kiddos arrest and show up in a code type status, generally it's due to a respiratory problem, and that often involves the airway. Infants are obligate nasal breathers. We need to keep that in mind that generally these small pediatric patients do breathe through their nose primarily, and suctioning that nose is quite important. Also to remember a large head to body ratio. The prominent occiput in pediatric patients when laying them supine quite often can cause their airway to occlude. So we need to be cautious about that and reposition them. The way to reposition them, a couple of tools to use in repositioning the head for airway compromise is the head tilt chin lift method, and also placing a towel roll under the shoulders, which we will demonstrate here shortly. Remember, these pediatric patients also have a large tongue, which can often occlude the airway and cause difficulty. May need to reposition that tongue. And again, remembering that they are nasal breathers, to always clear that nasal portion of their airway. Large adenoids and tonsils can play a role in airway management with kiddos. And again, often repositioning, suctioning will clear and open the airway and improve the status of the infant. These seem like simple things, but often simple things will correct big problems in terms of airway management in small pediatric patients. Again, repositioning and suctioning often make a big difference. We'll talk now about causes of airway issues. There are several. We think about infectious causes, including croup, which affects the upper airways, bacterial tracheitis, a retropharyngeal abscess like a peritonsillar abscess, enlargement of the lymphatic tissue, which can go along with mononucleosis, and then obviously enlargement of the epiglottis, which occurs in epiglottitis. Again, all infectious problems, all which may need to be addressed when there's an airway issue in these pediatric patients. Foreign body occlusion does occur periodically, and we'll talk about how to clear that here shortly. Trauma may also play a role in causing airway issues. That includes blunt or penetrating trauma, also burns. Remember that inhalation injury can cause significant problems in the airway and need to be addressed and treated promptly. Anaphylaxis is another cause of airway issues. This can cause anaphylaxis, and allergic reaction is another cause of airway issues. This can cause swelling in the upper airways as well as collapse of the lower airways. So we want to be very cautious and careful to recognize that early on in allergic reactions. Occasionally, we'll see kids with congenital abnormalities like Pierre-Robin syndrome, where they're just anatomic abnormalities which compromise the airway. In addition, laryngospasm, decreased oropharyngeal muscular tone, and airway secretions or bleeding can cause other issues with the airway, causing it to occlude. A specific example of airway compromise occurs in the child who is choking. Removal of the foreign body, which is causing the child to choke, is important. We want to start with positioning the kiddo. In a small pediatric patient, that means placing the child in your arm as demonstrated in the illustration there. And then to start with 5 back blows and follow that with 5 chest compressions. Again, this is in the infant or small pediatric patient. In larger kiddos, you can see that's the sitting method where the child is seated in the chair as demonstrated in the illustration. That, followed by 5 back blows or 5 abdominal thrusts, will often clear the foreign body and allow the child's airway to be open and breathing to continue. Just a reminder, we should only clear the foreign body from the mouth using a finger sweep if we are able to see the object. Do not do any blind finger sweeps. Continue the alternating back blows and chest thrusts, or back blows and abdominal compressions, until the foreign body is removed. As we consider how to approach airway issues, we want to identify and address the underlying cause. What is causing the airway to be compromised? And then to address it as necessary. We want to position the airway in such a way to optimize airflow from the nose and mouth to the lungs. Suction as needed and medications as appropriate. That may include bronchodilators, epinephrine, antihistamines, or steroids. We always want to supply supplemental oxygen. Anytime there's an airway issue, applying supplemental oxygen is beneficial. And then we want to establish an airway. If that means an endotracheal tube, or even needle cricothyrotomy, or jet ventilation, or surgical cricothyrotomy, we must get an airway when the airway is compromised. A few pearls regarding intubation. Remember that there are anatomic differences in pediatric patients. Their airway is higher, it's more anterior, and their epiglottis is floppier than it is in adults. Positioning is very important in being successful with intubating a pediatric patient. You may need a towel roll behind the shoulders. Always supply supplemental oxygen. Have suction and equipment available. A Broslow tape is important in determining the appropriate size tube. And remember, when using the Broslow tape, red to the head. The red portion of the Broslow tape represents the end of the tape that should be placed at the head and then measured distally. Want to always have an ambu mag and an appropriate size mask. Endotracheal tube of appropriate size with a half size up and a half size down. And keep in mind that we always want to use cuffed tubes. The days of uncuffed tubes are in the past. We want to use cuffed tubes even in these pediatric patients. We want an appropriate stylet. We need a syringe and the appropriately sized laryngoscope for the patient. We may also require medications for rapid sequence intubation, pre-treatment with medications such as atropine, as these kiddos are prone to bradycardia. May need to use some fentanyl for pain control, and even lidocaine may be given in order to avoid cardiac dysrhythmias. Do want to provide sedation for kids that we're intubating. That can come in the form of Versed or ketamine, maybe even etomidate, and then a paralytic, including rocuronium or vecuronium, as we approach medicating kiddos prior to intubation. Following intubation, we always want to auscultate to be sure that our tube is in the right position. Breath sounds only on the right side would indicate that the tube is too deep, and we have a right main stem intubation. Would want to back that tube out until we hear equal breath sounds on both sides. Always want to measure end-tidal CO2 using colorimetric devices or capnography, and then obviously a chest x-ray for confirmation of tube placement. When placing a towel roll, please recognize that the towel roll goes under the shoulders, not the head. It's that large occiput that's already compromising the airway. We want to get the towel roll under the shoulders to allow that child's head to fall backwards more and open the airway to a more anatomic position. So the towel roll goes under the shoulders, not the head. This is just a list of RSI medications. We'd be happy for you to reference this at any time. It gives dosages. These dosages can also be found on the Broslow tape. Just recognize that there are medications for pre-treatment, medications to use for sedation, and paralytics as well. Just a few pearls when it comes to airway and airway issues. Positioning and preparation are vital. The towel roll goes behind the shoulders. We want to have all our equipment available and have a plan A, B, and C readily available for the intubation. The Broslow tape is essential in determining dosages of medications and also sizes of equipment. The pediatric airway, remember, has anatomic differences. It's more superior anterior, and that epiglottis is floppier than we find in the adult patients. In patients under 2 years old, I would encourage you to use a Miller blade. It allows you to control the epiglottis better than a Macintosh. If you meet resistance once passing the tube through the cords, go to a tube that is a half size smaller. The most narrow portion of the pediatric airway is at the level of the cricoid cartilage, just distal to the vocal cords. And so if the tube that you have is too large and just won't pass through, if the tube that you have is too large and just won't pass through, go to a size that is a half size smaller. Only paralyze these kiddos if you're confident that you can oxygenate and ventilate them with a BVM in the case of a failed attempt. I would stress this especially in the patient with angioedema or a swollen tongue. Only paralyze if you are confident that you can oxygenate and ventilate with the bag valve mask in the case of a failed attempt. A case where I would really stress not using paralytics is in the case of angioedema or a large and swollen tongue. Paralyzing those patients removes their respiratory drive, and they can be very difficult to bag with a BVM. And then finally, if you are a ketamine user, and I find ketamine to be very useful in intubation, please recognize that ketamine should not be used for children less than 3 months of age due to potential complications. Let me encourage you, when approaching the airway of a child, make sure you plan, make sure you prepare, and then perform well. We'll move on to a surgical airway. Certainly, this is a last-ditched effort when an airway cannot be established otherwise. In children less than 8 years old, the appropriate approach to a surgical airway is with a needle cricothyrotomy. In children 8 years and older, a traditional surgical cricothyrotomy is the surgical airway of choice. When performing a needle cricothyrotomy, we want to identify the cricothyroid membrane. It's found between the thyroid cartilage and the cricoid cartilage. We want to use a 14-gauge angiocath and connect that to a 10 cc syringe. We puncture the membrane through the skin in a caudally directed angle, withdrawing with negative pressure on the syringe. And when air starts to fill the syringe, we stop, recognizing that we're in the airway. We would then slide the 14-gauge angiocath off of the needle and leave it in place and use it as an airway. We would leave the angiocath in place and use it as an airway through which we can oxygenate the patient. Keep in mind that needle cricothyrotomy is really good for oxygenation, but it is not good for ventilation. It is a must that we get a definitive airway within an hour. In children 8 years old or older, a surgical cricothyrotomy is the preferred method of surgical airway management. Again, we identify the thyroid cartilage and secure it between our thumb and middle finger of our non-dominant hand. We'd make a midline incision. It's a vertical incision and should be exactly midline over the cricothyroid membrane. We then palpate in our incision and feel for the membrane itself. We puncture the membrane with a scalpel, and then leaving the scalpel in place, you can slide a bougie into the hole of the membrane and into the airway. It's at that point we can slide an endotracheal tube over the bougie, or a tracheostomy tube for that matter, placing the ET tube or the tracheostomy tube into the airway itself. We then want to secure the tube in place. It is without a doubt that we hope not to have to perform a surgical airway on a child. But if there are no other options, we want to be prepared to do so, and reviewing these steps on a frequent basis will allow you to be as prepared as possible. We do need to manage the patient post-intubation. Management of the patient includes confirmation of tube placement. We want to make sure it's in the right place. Capnography and auscultation are important to that. We want to secure the tube, make sure that it is secure and not going to move upward or downward. In addition, we want to place an OG or an NG tube, because we want the child's stomach to be empty and therefore decrease the risk of complication. Further aspects of confirmation of tube placement include the chest x-ray, which is very helpful for determining the depth of the tube and being sure that it is above the carina and in the trachea. We want to know our ventilator settings. We often use pressure control in pediatric patients, and then post-intubation sedation is necessary. In kiddos, that is often best accomplished with Versed, fentanyl, or propofol. This is just an example of ventilator settings for children. Remember, it is a pressure-controlled, not volume-controlled ventilation. We always want to start with 100% FiO2. We can trend that downward according to the patient's O2 sats. The respiratory rate that we set should parallel either the normal respiratory rate or the pathophysiologic rate of the child who presents. The child who presents with tachypnea due to DKA needs a higher respiratory rate set on the ventilator in order to blow off that CO2 and compensate for the metabolic acidosis which is present. We want to set our inspiratory times, our PEEP, to about 3 to 5 centimeters of water. Tidal volume, somewhere around 5 to 8 milliliters per kilogram. And then pressure support between 4 and 6 centimeters of water as well. Our goal is peak inspiratory pressures of less than 28. We move now from airway to breathing. There are two components of breathing, which are oxygenation and ventilation. We must have both working in order to have a healthy patient. Signs of respiratory distress include tachypnea, tachycardia. You may see grunting and nasal flaring, retractions, cyanosis. We may hear wheezing, which is a sign of lower airway problems. We may hear stridor, a sign of upper airway problems. We'll see use of accessory muscles, maybe an altered level of consciousness, and body positioning. All can represent signs of difficulty breathing. Illnesses which cause difficulty in breathing may include croup, epiglottitis, RSV, asthma, and many others. We'll talk briefly about croup. There are really 4 elements of treating this disease. Remember, it's caused by a viral infection and affects the upper airways. We may hear that high-pitched stridor on inspiration and also hear a croupy cough, that barking cough that sounds like a seal. We want to use supplemental oxygen, and we want to use humidified air. Medications which may be used include a single dose of dexamethasone. We may also choose to use racemic epinephrine, although in certain areas that has fallen out of favor due to rebound effects. But always oxygen, humidified oxygen, corticosteroids, again that single dose of dexamethasone, and consider racemic epinephrine in severe cases. Epiglottitis, a disease that none of us want to see, but it does occur. This is an infection of the epiglottis, which causes severe swelling, with the epiglottis being the doorway to the airway. Any swelling in that area will compromise the airway. Again, a bacterial infection caused by Haemophilus influenza most commonly. These kiddos look toxic. They lean forward with their chin stuck forward and doing everything they can to keep their airway open. You may see drooling and difficulty controlling secretions as well. Let me encourage you, when you see a patient who looks like that, do not examine the posterior pharynx. Doing so can cause spasm of the posterior pharynx and can cause acute airway occlusion. It is important in these patients to secure the airway. You want to make sure you have your best airway resources available. If that's you, that's great, that's fine. If there's someone better in-house or readily available, get them to your facility. If there is someone better in-house or readily available, get them to the bedside to help care for this patient. It is best if the intubation can occur in the OR, if at all possible. Be prepared for a surgical airway. Be going through the steps in your mind of either needle cricothyrotomy or surgical cricothyrotomy, depending on the age of the patient. These patients will need IV fluids. They'll also need IV antibiotics. The cephalosporins are a great group to consider in treating Haemophilus influenza. There's also some benefit to giving corticosteroids as well. RSV. The wintertime holds multiple infections, but RSV is one that is most common, especially in pediatric patients. I'll reference here just a copious amount of secretions, and we'll do so by saying snot, snot, and more snot. RSV upper respiratory infection causes copious secretions in the nasal airways. We talked about infants being obligate nasal breathers. It's important in those patients to suction the nares just as quickly and often as possible. RSV bronchiolitis affects the lower airways. It will cause wheezing and is more prominent. You may see decreased O2 saturations in these patients. The treatment for RSV is supportive. We want to keep the oxygen saturation above 90%, which may mean giving supplemental oxygen. Want to be sure to maintain hydration and nutrition, and encourage suction to remove all of those secretions which are interfering with respiration. Do not use bronchodilators, steroids, antibiotics, epinephrine. Uh, the treatment of RSV, again, is supportive care, oxygenation, maintaining those SATs, providing hydration and nutrition. Move on to another disease of the lower airways, which is asthma. The treatment of asthma includes nebulized bronchodilators, including albuterol and Atrovent, corticosteroids such as IV Solumedrol. In severe cases, we may even want to add aminophylline or magnesium, and subcutaneous breathine or terbutaline can be used as well. The goal here being to reduce the bronchospasm and inflammation in the lower airways, allowing them to reinflate, open up, and improve breathing. This is simply a chart of asthma medications with appropriate dosages. I would encourage you to reference it and use it when needed. We move on now to C, circulation. Keep in mind that cardiac output equals heart rate times stroke volume. The rate that the heart is beating and the amount of blood that it pumps out with each beat represents cardiac output. It's this blood flow to the vital organs that keeps the body working and working well and in a healthy manner. Any compromise in cardiac output can have adverse consequences to the patient. In pediatric patients, remember that children have a greater fluid requirement due to higher metabolic rate and higher insensible losses due to increased surface area. Children do have a high cardiac reserve. They compensate quite well, and they do so by raising their heart rates. When we see hypotension in a child as a late finding, we need to recognize it immediately and that this child is in dire need of intervention. Signs of volume depletion include decreased urine output, dry mucous membranes, decreased skin turgor, tachycardia, prolonged capillary refill, and abnormal respiratory pattern. You may also see altered mental status. As we touch on capillary refill, let me encourage you to always check that, not just distally in the nail beds as we've been taught in the past, but also to check the core. Checking capillary refill over the sternum is a great way to assess the circulation status of the patient. Oral rehydration is preferred to IV hydration when it is possible, and in mild to moderate cases of dehydration, oral hydration is certainly the preferred route. In considering and providing maintenance fluids, remember that for the first 10 kilograms, it's 100 milligrams per kilogram per 24 hours. For the kilograms between 10 and 20, it's an additional 50 cc's per kilogram per 24 hours. In considering circulation and providing IV fluids, we always want to consider maintenance fluids as well and providing them in the appropriate ratio based on weight. Here are some formulas for calculating maintenance fluids. This is for your reference. Please utilize it as you see fit. We'll now talk about shock, a severe complication of circulatory status. Shock is a life-threatening condition as a result of insufficient tissue and organ perfusion. It comes in a variety of forms, including hypovolemic shock, cardiogenic shock, where the heart is just not pumping adequately, septic shock, in which vasodilation occurs due to the body's response to an infection, anaphylactic shock, and neurogenic shock finish out the list. The most common reason for shock in pediatric patients is hypovolemic. Generally, this is due to a loss of blood or body fluids, generally due to nausea, vomiting, diarrhea. May see it with hemorrhage due to trauma or loss of blood due to a GI bleed. Treatment always begins with IV crystalloid, and the bolus is at 20 milliliters per kilogram. We want to reassess after each bolus to see how the child is responding to our treatment. We may want to give up to a total of 60 milliliters per kilogram of crystalloid before determining the child's final response. If hemorrhage is suspected, we want to start transfusion of packed red blood cells. When giving packed red cells, that's done at a rate of 10 milliliters per kilogram. Then we reassess after each transfusion. In the case of sepsis, we always want to work the patient up appropriately. That includes the sepsis bundle, including CBC, chemistries, PT, PTT, cardiac enzymes, blood cultures, lactic acid, C-reactive protein, procalcitonin, a chest x-ray, and a urinalysis. Once the workup is initiated and underway, assuming the child is indeed in shock due to sepsis, we want to give an IV fluid bolus with a target of 30 milliliters per kilogram. In addition, we want to start broad spectrum IV antibiotics until we find the source of infection. We don't know the source. Broad spectrum antibiotics are the key. Once we've identified the source of infection, though, we can narrow the coverage to more appropriate and targeted therapy based on the specific illness. When blood pressure is refractory to crystalloid bolus, pressors may become necessary, with Levophed being the preferred pressor for septic shock. In the case of anaphylactic shock, we always want to keep in mind the airway. If the airway is compromised, we want to secure that as best we can and as quickly as possible. We want to get rid of the substances causing the anaphylaxis. If it's still present, we want to provide decontamination. Medications to be given include epinephrine that should be given IM and not sub-Q as we once did. Also want to provide antihistamines, both H1 and H2 blockers. Corticosteroids and bronchodilators are helpful as well. And we may need IV fluids to support blood pressure in the case of true anaphylactic shock. Blood pressure which is refractory to crystalloid bolus may require vasopressors, and we want to consider epinephrine or Levophed in these cases to support blood pressure. This is a pretty complex slide. It represents a pediatric shock algorithm. We won't go through it in detail, but I would encourage you to reference it as needed. We move now from ABC to D. D is disability. The Glasgow Coma Scale is very important, even in pediatric patients. The two things that we measure in pediatric patients are eye opening and verbal response. Remember that their verbal response will not be the same as an adult patient. So we want to keep in mind the nuances of the pediatric patient as we consider the GCS. We'll touch now just briefly on several specific topics. We'll start with pediatric hypertension and the treatment thereof. Medications to be used here include hydralazine, labetalol, and nicardipine. You can see there the dosages available on those medications. Pediatric hypertension is not a common emergency, but we do want to be prepared to take care of it when necessary, and these are the medications we should consider in treating it. Pediatric hyperkalemia, just as in the adult patient, hyperkalemia can be very dangerous and cause cardiac arrhythmias. We want to treat that in an efficient fashion, getting rid of the potassium and reducing its levels in the serum. In order to do so, we want to stabilize the myocardium using calcium. Generally, a dose of calcium gluconate is given peripherally. We also use regular insulin and dextrose. The combination of those two medicines drives potassium from the serum and into the intracellular space where it's no longer dangerous to the patient. Remember that this is just temporary, as it will eventually leak back out of the cells and will need to be removed in another way. Other ways to reduce potassium in the serum include albuterol, which can be given as a nebulized treatment. Also, sodium bicarbonate is helpful in treating these patients, and then giving IV Lasix will also allow potassium to be removed in the urine. K-exhalate given orally or in the form of an enema is a final definitive treatment for hyperkalemia, as it extracts the potassium from the extracellular space and removes it from the body. This is simply a list of critical care medications and their dosages. Some are pressors, some are for blood pressure control, others for treatment of elevated glucose, others for the use in treating hypertension. I would encourage you to reference these dosages and use them as needed. This is another list of medications used in resuscitation. All of these can be found on the Broslow tape when needed and to be used in the case of a code or resuscitation scenario. Another very specific problem, which occurs commonly in pediatric patients, are seizures. When these kiddos present with status epilepticus, meaning multiple seizures or seizures which are uncontrolled, they must be treated and treated effectively. This is a list of medications which can be given for that purpose. It includes multiple benzodiazepines, including Versed and Ativan, which are used very commonly, as well as Valium. Other more definitive treatments for the seizure disorder include Dilantin or Cerebix, represented by phosphatonin on the chart there. These are the dosages to be considered. We encourage you to reference that in the case of seizing patients or patients that you find in status epilepticus. This is a list of commonly used antibiotics and antivirals. You can reference that when treating infections, especially sepsis. The dosages are included here, and I encourage you to reference that as needed. In patients who present with overdose or with difficulties and problems maybe created by some of our treatment, we do have reversal agents, the use of naloxone to treat opiate overdose, the use of flamazanil to treat benzodiazepine overdose, and the use of glucagon, which is used in the treatment of overdose on beta blockers. We've really come very near to the end of our pediatric emergencies talk. Before we finish, though, I would like to touch on one subject which is not included in the slide deck, and that is the concept of sedation or procedural sedation in treating children who need laceration closures, maybe reduction of fractures, or other procedures we do in the emergency department. The old school days of simply holding a kid down, putting them through the torture of whatever procedure we're going to perform are gone. We have multiple agents which are helpful in the process of sedating children to a point where we can get those procedures done and not cause them long-term psychological harm. Quite often, just reducing the anxiety of the procedure is helpful, and that can be done with the use of intranasal Versed and be done quite effectively. In cases where more sedation is needed, ketamine can be a very useful tool in that regard, and other medications as well. In preparing for conscious sedation or sedation of any kind, we always want to monitor the child closely. We want to provide supplemental oxygen, have them on a cardiac monitor with pulse oximetry. While we've discussed just briefly the use of sedation in pediatric patients for emergency procedures, we will provide supplemental information along with this video that you can access for your own use and your own reference. There are a great many details in that piece of literature that we have not touched on in the video, so let me encourage you to reference that when considering sedation in pediatric patients. We've used multiple references in presenting the information today. Two of those references include Pediatric Emergent Management, presented by Cook Children's Hospital in Fort Worth, Texas, and also EMRA.org, Airway Pediatric Emergency Medicine, difficult to ventilate and oxygenate. It's the Pediatric Airway Review, as presented by physicians Zaza Atinilov, Gwen Hooley, and Sylvia Garcia. Much thanks to all of those for providing those references to us. I appreciate the great work that all of you do in taking care of all of our patients, especially the young ones. These pediatric patients come in and often cause a great deal of stress among the staff, but having confidence and knowledge behind you to treat them and treat them effectively should hopefully reduce that stress and improve outcomes. I appreciate your time in watching the video today. We have multiple resources available. Feel free to reach out if you have any questions or concerns. Thank you again. Have a great day. Appreciate all the work you do for Concord Medical Group. Take care.